Welcome back, guys. And here we will cover chapters 22, 23, and 28. Those will review GI, GU, and endocrine. First, we will start with the GU alterations in chapter 22. Alright, looking at chapter 22, this will review GU alterations, or your genital urinary alterations, but for short, we will say GU during this chapter. I want you guys to go ahead and read and review your anatomy and physiology for the GU system. I also want you to look at the nursing tip in your text on 698 and 99 as far as calculating bladder volume and calculating the minimum urine output for infants. This is especially important when looking to take care of the infant clientele. And first we will go ahead and look at the urinary tract infections. This is an infection of one or more structures of the urinary tract and can be classified as lower UTIs or upper urinary tract, which is your pyelonephritis or your cystitis. The most common site is the bladder, which is cystitis, with infection confined to the urethra called urethritis, and to the kidneys, which is known as your pyelonephritis. Pyelonephritis is usually considered more severe and is accompanied by an increase in the severity of symptoms. UTI is the most common disorder of the GU tract. The most common bacterial organism that affects the UT tract, or the urinary tract, is your E. coli, likely because of its presence in the gastrointestinal tract and perianal skin. When we look at the pathophysiology, and I do want you to know, I do not normally go over the pathophysiology. I do want you guys to review that along with your A&P. I just want to point out a couple of things in there that are pertinent. You want to know that females, of course, are especially at risk for infection because of the structure of the lower urinary tract and the short urethra. Males are less susceptible to the UTI because of the longer urethra and secretions from the prostate that have an antibacterial property. Therefore, when UTI is found in males, it is important to investigate for urinary tract abnormalities. Normally, emptying the bladder frequently completely washes out any organisms. When we look at the clinical manifestations, the presenting signs and symptoms of UTI are often vague, especially in young children. Symptoms in the older child generally include malodorous urine, dysuria, or difficult or painful urination, urinary frequency, fever, vomiting, diarrhea, irritability, poor feeding, or loss of appetite. Typically, this is distinguished from pyelonephritis, a syndrome involving fever, often greater than 101 degrees Fahrenheit, chills, and back pain. Children with pyelonephritis will also appear to be quite ill. When we look at diagnosis, a UA and urine culture with sensitivity will be performed to diagnose the UTI. An adequate specimen for a child is usually 5 to 10 cc's of urine, or 5 to 10 mLs of urine. The healthcare provider may recommend a renal scanning to identify anatomic abnormalities that may cause or may be the cause of UTI, especially when you're looking at this in the male. I do want you guys to also look at table 22-1 in your text on page 700, which goes over the clinical manifestations of UTI in children of various ages. When we look at treatment, this includes, first, eradicating the infection, second, preventing reinfection by identifying contributing factors, third, correcting underlying causes of infection, and fourth, preserving renal function. Treatment depends upon a variety of factors, including the child's age, other existing medical conditions, and his or her ability to maintain hydration. Oral antibiotic therapy is used to treat UTI. Antibiotics such as Bactrim, amoxicillin, those are your common ones that you will see. A cephalosporin may be used, and they are given for 7 to 10 days. A follow-up urine culture should be performed 48 to 72 hours after initiating treatment. For infants or young children 2 months to 2 years of age who are assessed as toxic, dehydrated, or unable to retain oral fluids, initial antibiotic therapy should be given intravenously, and hospitalization should be considered. Now we'll look at enuresis. This is defined as an involuntary voiding of urine beyond the expected age at which voluntary control should be achieved after successful toilet training. This differs from incontinence in that incontinence results from structural abnormalities, usually an anatomic malformation. Note that it can be primary or secondary. A child who has never achieved a period of dryness for at least 3 months is referred to as a primary. Secondary enuresis occurs when a child has been dry for at least 3 to 6 months and then resumes wetting. Diurnal enuresis is wetting that occurs only during the daytime, and nocturnal enuresis is wetting that occurs at night. Go ahead and review the etiology and pathophysiology when it comes to enuresis. And we will look at clinical manifestations. Most children achieve urinary and bowel control between 2.5 to 3.5 years of age. The typical sequence for development of bladder and bowel control is first, nocturnal bowel control, second, daytime bowel control, third, daytime control of voiding, and then lastly, nighttime control of voiding. It is unclear why some children are not able to accomplish bladder control while other children of the same age have obtained control. Any child who continues to experience nighttime wetting after the age of 5 warrants an evaluation for enuresis. Diagnosis is based upon physical examination, a careful family history, and hallmarks of determining how enuresis actually started. A thorough physical exam, of course, to distinguish between organic and non-organic enuresis should be performed. Results of the history, voiding diary, and physical exam may determine which diagnostic tests are required for further evaluation. Some of the more frequently required tests include your urinalysis, your urine cultures, renal ultrasounds, and the VCUG for children with a history of UTIs. Treatment. The following treatments can be used separately or in combination to treat children with wetting problems: medication, bedwetting alarms, motivational therapies, elimination diets, and bowel programs for children who are constipated. The most common medication to use to treat enuresis is the desmopressin, or your DDAVP. You may have also seen diptrophan, and tofranil is one of the other ones. I do want you to look at the nursing alert in your text on page 706 that goes over DDAVP, which is your desmopressin, and this is the one that you'll see most often, as well as warnings for the tofranil overdose. This one you don't see as often. You will see the desmopressin quite often. Bedwetting alarms are widely used for treatment of enuresis as well. The alarm starts to buzz as the first few drops of urine are detected. This usually wakes the child up and alerts them to go to the bathroom. Now, of course, when this is first done, it will scare the living daylights out of the child, but it does seem to work. Also, motivational therapies may include star charts to record the child's progress during the treatment program, and of course, encouraging the parents and caregivers to motivate the child and putting the child on some type of schedule may help. Certain foods may be irritants to the bladder and increase a child's wetting problems. Eliminating foods or beverages that are known irritants may decrease the number of wetting episodes the child has. Foods to eliminate include carbonated beverages, dairy products, beverages with artificial flavoring, citric fruit, heavily sugared foods, and beverages with caffeine. 5 to 10% of children with enuresis benefit from the elimination diet. When we look at family teaching, nurses can provide children and caregivers with information on hygiene and treatment or prevention of skin breakdown caused by exposure to skin and urine. They will need education about the use of bedwetting alarms, explain to the caregivers that the child's sleep will be disrupted during the program and that it may be beneficial to the child to have an earlier bedtime. Nurses need to discuss with the child feelings of embarrassment or guilt as a result of enuresis, and the nurse should encourage keeping an extra set of clothes at school until the enuresis is resolved, and that is especially for those that have the daytime enuresis. Okay, now we'll look at vesicoureteral reflex, also known as VUR. This is defined as the backflow of urine from the bladder up to the ureter to the kidney. VUR results from uterovesical or vesicoureteral junction fails to maintain a unidirectional flow of urine from the ureter to the bladder. Normally, urine is produced in the kidneys and travels down the ureters into the bladder for storage. In the normal bladder, the junction of the ureter into the bladder forms a one-way valve mechanism or flap valve that allows urine to flow into the bladder while preventing regurgitation back into the ureters or the kidneys. Note that VUR is the most common anatomic disorder affecting the GU tract. Clinical manifestations are not directly apparent. However, persistent and repeated UTIs are the most frequent indicator of reflux. Therefore, children with repeated UTIs should be evaluated. Other manifestations of reflux less commonly seen are enuresis, flank pain, and abdominal pain. Diagnosis is made by radiographic evidence of backflow of urine on a cystogram or a voiding cystourethrogram or a VCUG. Reflux is graded to determine its severity on a scale of 1 to 5. The degree to which contrast material from the bladder travels up to the ureters to the kidneys is graded 1 to 5, with 1 being the least severe and 5 being the most severe. The medical treatment is determined by the severity of the reflux and the fact that some degrees of reflux resolve spontaneously as the child grows. The less severe the reflux, the greater the likelihood of resolution. The goals of medical management for children with reflux include prevention of UTIs, prevention of kidney damage, and prevention of subsequent complications of reflux and renal scarring. When we look at nursing management, because the non-surgical management for a child with VUR focuses on UTI prevention and management, an important aspect of nursing care focuses on the education of the child and the caregivers. If indeed surgery is necessary, the nurse provides the child and caregivers information about surgical procedures and preoperative and postoperative care. Immediate postoperative care for the child after reimplantation of one or both ureters can be challenging. While managing the acute pain of the child, It is important to strictly monitor intake and output. The well-organized nurse will label all drainage devices and stents and note where they originate. The nurse should assess the integrity of all tubes and drainage bags. Breaks in tubes can increase the risk for infection by introducing bacteria into the drainage system. Noting all kinks and disruptions will assure an accurate I&O. Now, we'll look at hypospadias. This is a common congenital malformation in which the urethral meatus is on the ventral surface or the underside of the penis. When we look at clinical manifestations, the prepuce or the skin forming a hood over the glands is abnormally small ventrally and may be redundant dorsally. Many caregivers of infants with hypospadias claim it appears that their newborn son has already been circumcised. Associated conditions include chordate or a downward curvature of the penis and an incomplete foreskin, undescended testicles, and an inguinal hernia. In some cases, the urinary stream may be deflected downward, secondary to the ventral position of the meatus. Diagnosis is, of course, made on physical examination. Treatment involves surgical correction of the chordate and placement of the urethral meatus to the top of the penis, or shall I say the tip of the penis. Surgery is usually performed before the child is 18 months of age, prior to toilet training and the development of body image or gender identity, thus minimizing the psychological trauma. On occasion, the size of the penis is augmented preoperatively with testosterone cream or injections to allow for growth of the tissue and thus facilitate surgery. If we look at the nursing management, preoperatively, the nurse should assess the infant or child for evidence of other GU defects such as undescended testicles, inguinal hernia, or hydrocele. Now we'll look at cryptorchidism. This is also known as your undescended testes, or UDT, and this is defined as failure of one or both testes to descend through the inguinal canal into the scrotum. It is a common urologic problem. UDT, which may be unilateral or bilateral, is unilateral in 85% of males and most often affects the right testes. One side of the scrotum, unilateral, or the entire scrotum, bilateral, appears flaccid, non-pendulous, and smaller than normal. Diagnosis involves primarily physical exam in which the scrotum is palpated for testes, a small nodule. If the testis is not palpable, ultrasound may be used to determine its location. Management of cryptorchidism may involve observation while awaiting spontaneous descent of the testes during the first year of life. Human chorionic gonadotropin, or your HCG, may also be used to stimulate testosterone production to help induce descent of the testes. The optimal timing for surgical correction is when the child is between 1 and 2 years of age. The goal of surgical correction are to bring the testes into the scrotum and secure it to the scrotal fixation without damaging the actual testicle. When we look at family teaching, nurses are helpful in teaching and preparing both the child and the caregiver for surgery. If HCG therapy is utilized, the caregiver should be aware of the desired effects as well as the secondary effects. Note that sutures and dressings are minimal. Usually dissolving sutures are utilized to close the groin and scrotal wound. Hence, the child does not require suture removal and may induce that may induce further fear and trauma. Tegaderm or other clear plastic tape dressings cover the groin wound and may be removed at home 1 week after surgery. Now we'll look at the inguinal hernia and hydrocele. They are similar disorders both clinically and in their treatment. The inguinal hernia is a scrotal or inguinal swelling, or both, that involves the abdominal contents. A hydrocele is a collection of peritoneal fluid in the scrotal sac. When we look at clinical manifestations, an inguinal hernia presents as a bulge or a swelling in the scrotum or groin whose size increases because of increased abdominal pressure from crying or straining. Pain is usually not associated with the hernia unless it becomes strangulated. Diagnosis of a hernia and hydrocele are based on physical exam of the scrotum and the inguinal area. Treatment of choice for an inguinal hernia is, of course, surgery. The procedure is done through an incision in the inguinal crease, and the prosthesis vaginalis is identified and ligated. The wound is often covered with a protective sealant after surgery, which is usually called Dermabond. A hydrocele usually resolves by 1 year of age. However, if it does not resolve spontaneously by this time, it means a hernia is present and should be surgically repaired. The procedure is called a hydroilectomy and is the same as for a hernia. As far as nursing management and family teaching goes, nursing care for the inguinal hernia and hydrocele focuses on teaching the caregivers about the surgical procedure, preoperative and postoperative care, and signs and symptoms of complications such as wound infection and strangulation preoperatively. Preoperatively, the nurse needs to be vigilant of signs of incarceration, which is the strangulation of a portion of the bowel leading to circulation impairment and tissue necrosis. After surgery, the surgical site is observed for bleeding, drainage, and reoccurrence of the hernia. Now we'll look at a few examples that talk about some of these GU alterations. First, we'll look at the UTI. If a child has a UTI, the nurse must first assess the child's usual voiding patterns. How are they voiding? Do they go to the bathroom, 2-3 times a day? If it's an infant, how often are they wetting the diaper? Is it, 6 to 8 times a day? Is it 3 to 4 times a day? How often are they eating? But that is the main thing that we want to assess, the child's usual voiding patterns. Also, when looking at the physiologic causes for a child to have enuresis, one of them may be sleeping too soundly. I know as adults we can go into our deep sleep and we don't wake up to actually urinate because our bladders are now basically trained to hold that urine for 8 hours. Whereas your kid, if they're used to sleeping for a long period of time and not waking up, then they may wet the bed. So as a parent or caregiver, you can then set your alarm to wake the child up in the middle of the night to go to the bathroom, or stop giving them fluids at a certain point in the evening before they go to bed. Usually we say like 2 to 4 hours before they go to bed, so that they have less fluid in their bladder as well. And when providing post-op care for a child who had hypospadias, an activity that will be appropriate is something like wheelchair kickball. I mean, they don't have to be on complete bed rest, but they shouldn't be doing a whole lot of activity while, standing. So we can get them in a wheelchair. And this is if the child is able to be up and active. So this would be like for your school age child, um, maybe even for your preschooler if we, had that type of play involved. But mainly for your school age and your adolescent if they want to partake in activities of that nature. Okay, we'll finish up GU alterations, and first we'll look at acute glomerulonephritis, or AGN. This is an acute or sudden inflammation of the glomeruli within the kidney. This inflammation can result in acute renal failure. When we look at clinical manifestations, they're usually hematuria or the presence of blood in the urine, dependent or periorbital edema, diminished urinary output, proteinuria, hypertension, fatigue, diminished glomerular filtration rates, elevated serum sodium levels, and elevated potassium. Most patients have hypertension, which is most likely due to fluid retention and vascular congestion. The diagnosis is dependent upon previously listed clinical manifestations, including a urine analysis which reveals hematuria, proteinuria, and an increased specific gravity. Other diagnostic tests, which include your WBC with differential, this may count or may not be within normal limits, depending on the length of infection and its severity. Treatment depends in part on the degree of kidney damage and if the patient is actually symptomatic. Children with normal blood pressures and urine output can usually be managed at home. However, those with generalized edema, significant oliguria, hypertension, and gross hematuria should be hospitalized because of the possibility of developing acute renal failure, hypertensive encephalopathy, or pulmonary congestion. If edema is generalized, it may be necessary to give diuretics. Antihypertensive agents are given for hypertension, and antibiotics are given only if there is an active bacterial infection. Dietary restrictions are based on the severity of the disorder, especially the extent of edema, hypertension, sodium, potassium, and fluids. They may all be restricted. You want to look at the family teaching box that goes over home care of a child with acute glomerulonephritis in your text on page 716. When we look at nephrotic syndrome, this is a clinical entity characterized by massive proteinuria leading to edema and hyperlipidemia. Clinical manifestations. These children exhibit some of the same symptoms as other children with renal failure. Edema is usually the first clinical feature. Initially, it is often mild, being periorbital in the early morning hours and becoming more generalized after the child has been ambulatory. Anorexia, abdominal pain or tenderness caused by inflammation of the kidney, abdominal swelling, fatigue, history of recent respiratory infection, increased weight or rapid weight gain, and vital signs within the normal range may also be noted. Hyperlipidemia is also present and must likely be due to increased hepatic lipid metabolism in response to the hypoproteinemia. Diagnosis is dependent upon the proteinuria, a serum albumin level. Those levels are diminished. Laboratory evaluation includes a urinalysis for protein, red blood cell count, serum albumin, serum cholesterol, triglycerides, hemoglobin, hematocrit, platelet counts, your electrolytes, your BUN, and creatinine. Treatment focuses on reducing proteinuria, controlling edema, and preventing infection. The mainstay of treatment is corticosteroid therapy with prednisone or prednisolone, which is your prelone, in order to obtain a remission. Note that they do decrease the inflammation and loss of proteins, thus restoring ontonic pressure and promoting diuresis. Nursing management focuses on maintaining fluid and electrolyte balance, administering medications, preventing infection and skin breakdown, and patient family education. The child's vital signs should be monitored every 4 hours, at least every shift. Low blood pressure and tachycardia are signs of hypovolemia and should be reported immediately. Any urine output less than 1 to 2 milligrams per kilo per hour is to be reported immediately. Serum and urine electrolyte tests, as ordered, need to be evaluated. Nurses should assess for signs of edema and dehydration on a regular basis. As far as family teaching, nurses should explain to caregivers what is known about nephrotic syndrome and its expected course. Caregivers should be allowed to ask questions and express their feelings. Nurses must teach the caregivers how to perform urine dipstick protein level measurements and the importance of measuring and recording the readings daily. Looking at hemolytic uremic syndrome, or your HUS, an acute disease, is the most frequent cause of acute renal failure in children. The clinical manifestations are a tirade of symptoms which include acute renal failure, thrombocytopenia, and anemia. Diagnosis. When we look at diagnosis, mild proteinuria may be present. Serum creatinine and BUN levels are also elevated. Your CBC will indicate anemia and thrombocytopenia. Other coagulation studies may also be done. A stool culture may also be done to determine the presence of E. coli and the Shigella bacteria. Primarily, the treatment is symptomatic. If the serum electrolytes are outside of normal limits and renal failure is severe, hemo or peritoneal dialysis or fluid restriction may be necessary to raise the serum sodium levels that have fallen because of the dilutional or volume overload. Dialysis is most often reserved for children who are anuritic or without urine output for 24 hours or have oliguria and are extremely hypertensive, hyperkalemic, or experiencing seizures. Calcium and phosphorus levels are affected, with calcium falling and phosphorus rising. Treatment for hypertension is accomplished with hydralazine and captopril. The child may also be in metabolic acidosis from the inability of the kidneys to buffer acids normally produced in the body and may require bicarbonate therapy as well. Nursing management focuses on maintaining renal function and fluid and electrolyte balance and providing family support. Nurses should assess the child for signs and symptoms of dehydration, increased temperature, post-respiration, falling blood pressure, decreased peripheral perfusion, dry skin and mucous membranes, decreased urine output with a rising urine-specific gravity, and poor skin turgor. The child is assessed for signs of fluid overload, such as tachycardia, tachypnea, hypertension, visible edema, and increased pulmonary secretions. The child is evaluated for signs of bleeding or injury related to the thrombocytopenia, and any signs of petechiae, bleeding, excessive bruising, or rashes are and should be documented. Nurses should assess the child for signs of possible increased intracranial pressure as well, and they should assess for gastrointestinal disturbances, document any vomits, stools, and describe their characteristics. Now, looking at renal failure. Renal failure refers to a condition that adversely affects the kidney, resulting in decreased functioning of this organ system. It takes two main forms, acute and chronic. First, we'll look at acute renal failure, formerly known as, now it's known as acute renal acute kidney injury, and it was formerly known as acute renal failure. People still refer to it as acute renal failure, so you probably will rarely hear it called acute renal injury. But it is uncommon in children, but it can be life-threatening when it does develop. Of course, the exact instance of it does seem to be a rise in the number of hospitalized children who develop acute renal failure. So why is that? Of course, the most common clinical manifestations are your oliguria, fluid and electrolyte imbalances, metabolic acidosis, and signs of dehydration or edema that result from kidneys' inability to maintain balance. Pallor, listlessness, lethargy, anorexia, vomiting, and in some cases seizures may be observed. Diagnosis is based on history, laboratory evaluation, and physical exam. Anuria or urine output of 1 milliliter per kilo per hour is a potential finding, although some children will have a normal volume of urine output. Renal serum panel usually reveals a rising BUN and creatinine. Serum electrolytes, especially sodium and potassium, may also be elevated and life-threatening. The aims of treatment for a child with acute renal failure are to increase renal perfusion, restore and maintain fluid and electrolyte and acid-base balance to minimize complications, and to promote nutrition. You can review renal replacement therapy, which goes over hemodialysis and peritoneal dialysis. When we look at family teaching, of course, fear and anxiety are real emotions for the caregivers of the child with acute renal injury. They need to be honest and thorough explanations about what is known about the cause and the expected outcome or course of the illness. For the child and family who's undergoing dialysis, teaching regarding treatments, home care, and what they will experience is very much essential. When we look at chronic renal failure and end-stage renal disease, this is a progressive disease. The damage that is done to the renal system in some cases is irreversible. This condition is considered chronic when approximately 50% of the renal function remains, or when the glomerular filtration rate is less than 60 mLs per minute, knowing that the normal is 125 mLs per minute, and the condition has lasted for at least 3 months. All chronic renal failure will first progress to uremia. This is a condition in which toxic nitrogenous waste product, blood urea, and creatinine build up in the system. If this condition is not reversed, it progresses to end-stage renal disease, or your ESRD. With acute renal failure, the main clinical manifestations of CRF and ESRD include fluid and electrolyte imbalance, dehydration or edema, metabolic acidosis, and systemic hypertension. Diagnosis is based on history of either long-standing renal problems or growth problems accompanied by altered laboratory values. Treatment for the child with CRF and ESRD is aimed at restoring or maintaining fluid and electrolyte balance. Other therapies include erythropoietin to combat anemia and growth hormone to boost linear growth. Renal transplantation is usually reserved for children in the ESRD phase, for whom medication and dietary management of fluid and electrolyte balance and hypertension have been unsuccessful. Kidneys for transplantation are obtained either through the living donor, usually close relatives or cadavers. Transplantation is just one aspect of ESRD treatment. Post-transplantation immunosuppressive medications, those are required for life. There are several concerns about the long-term effects of steroid and cyclosporin therapy. Both of these medications increase the susceptibility to infection, as previously mentioned. So when we look at nursing management, nurses should administer medications as ordered and assess for signs of infection, elevated temperatures, changing CBCs with differential coughs, sore throat, and other systemic complaints. The child should be protected from visitors or personnel who have infections. Antibiotics are administered as ordered. Nurses should always consider if these medications are cleared through the kidney. If so, peak and trough levels must be monitored, as some medications may be nephrotoxic or toxic to the kidney. If anemia is severe, blood transfusions with packed red blood cells may be administered. And the post-transplant assessment and care remains the same as described for the child with the family with CRF and ESRD. These children are at risk for development of vesicoureteral reflux in the graft, which may lead to pyelonephritis. So when we look at family teaching, because either CRF or ESRD is chronic, lifelong problem, the family will have many learning needs, especially related to the need of meticulous follow-up care. Families also need to know that generally childhood immunizations should be given and that there is no effect on the kidney. Lastly, we'll look at bladder esophageal epispadias complex. That's a lot to say, isn't it? I abbreviate everything, so this one will be BEEC. Your Beck. We'll call it the Beck. Okay? Alright, so this is a rare, serious, congenital anomaly affecting the urologic and musculoskeletal system. Musculoskeletal anomalies seen in these children include an outward rotation of the hips and widening of the pelvis. Male infants have a short penis with dorsal chordae or upward curvature and a ventral prepuce. Females present with a bifid clitoris and non-fused labia. At birth, the bladder mucosa is thin, reddened, and susceptible to injury. Surgical management of this condition is usually performed within the first 48 hours of life, but may be deferred secondarily to the infant's stability or until further testing is performed. Goals of management include preservation of the primary bladder and abdominal wall and provision of an adequate pelvic structure to support the bladder. Other goals include achievement of functional bladder and cosmetic reconstruction to preserve kidney and bladder function. Initially, the bladder, abdominal wall, and symphysis are closed surgically. Long-term care focuses on continence issues and social adjustment. There is a figure in your text on page 732 that gives you an example of how this Beck disorder actually looks. And one quick example before we end out this chapter, and it is about acute renal failure and actually a renal transplant. So if you are looking or taking care of a child who has had an acute renal transplant rejection, if they receive Murinonab CD3, which is one of the medications that is used for renal transplant patients, the nurse needs to assess for a fever, chill, and chest tightness after the first dose. And this came up in the last test. I know someone had a question about asking about interactions with other drugs. If the child has not taken the drug before, then we do not know if there's an interaction. So we don't usually ask that question. If there has been an interaction with the drug, then usually that is listed in their allergies. We don't usually have to ask if there's an interaction. So, with that being said, after the first dose of that medication for the renal transplant rejection meds, we as the nurse need to assess for fevers, chills, and chest tightening. That will let us know if we can continue with dosing or if the healthcare provider needs to prescribe something else. And with that being said, that will complete chapter 22, which covers your genitourinary alterations. Okay, let's start with chapter 23, which will go over GI alterations, also known as your gastrointestinal alterations. I do want you guys to read and review your anatomy and physiology for that portion, and we will go straight into the upper gastrointestinal alterations, which first will cover hypertrophic pyloric stenosis, also known in short as pyloric stenosis. This is the most common intra-abdominal condition requiring surgery during the neonatal period. You want to note that the pylorus is an opening through which the food passes from the stomach to the intestines. The opening is surrounded by a muscular ring, the pyloric sphincter. In HPS, the pyloric sphincter hypertrophies and increases 4 times its normal width, resulting in a narrow opening and gastric outlet obstruction. The obstruction prevents gastric contents from emptying into the duodenum. Symptoms usually develop during the 3rd and 4th week of life. Non-bilious vomiting begins between the 2nd and 3rd week of life and is the initial symptom. Because of the progressive nature of the obstruction, the vomiting increases in frequency and eventually becomes projectile, with vomitus being propelled up to several feet. So it kind of looks like The Exorcist. The emesis is not bile stained because the obstruction occurs above the outlet of the bile duct. The infancy is hungry in spite of the vomiting and will usually feed again. Because food does not pass through the pylorus, bowel movements are small. As vomiting continues, there is loss of fluid, leading to dehydration, and hydrogen and chloride ions are lost, leading to hypokalemic metabolic alkalosis. Serum potassium levels are usually maintained, but there may be a total body potassium deficit. The infant has poor weight gain or experiences weight loss and becomes increasingly irritable and lethargic as dehydration and electrolyte imbalances worsen. Diagnosis is made on history and physical identification of the hypertrophic pylorus, which can sometimes be palpated as an olive-shaped mass in the epigastrium above and to the right, sometimes midline of the umbilicus. A surgical procedure called a pylomyomectomy is often the treatment of choice in which the circular muscle fibers are released, opening the passage from the stomach into the duodenum. This can be done in an open or laparoscopic surgery. Although both methods are effective ways to treat HPS, the laparoscopic approach results in less postoperative pain and reduced postoperative emesis. Sometimes medical management works and surgery is unnecessary. Postoperatively, the NG2 should be removed unless there is a reason to keep it in place, such as injury or perforation of the duodenum. Gastric motility is delayed for up to 24 hours following anesthesia. Therefore, Feeding should begin slowly and advance cautiously. Small and frequent feedings are resumed at 4 to 6 hours post-surgery. The surgical treatment for HPS has a high success rate and is considered curative. When we look at planning and implementation, what I do want to point out is post-operative care does include maintaining fluid and electrolyte balance by monitoring intravenous infusions until oral fluids are tolerated, monitoring the infant's response to feedings by mouth, and assessing for signs of dehydration. Most infants experience some vomiting in the first 24 to 36 hours, even after surgery. Intravenous fluids are administered until full feedings are tolerated. I do want you to look at the nursing alert and nursing tip in your text on page 742, which goes over the warning signs of hypertrophic pyloric stenosis and palpating that olive-shaped mass. When we look at family teaching, caregivers often feel ineffective and powerless because their baby has been hungry and yet they have not been able to satisfy this hunger. So, nurses can support them by explaining that it's not their fault and the condition is caused by the structural defect. Nurses should instruct caregivers about the care of the incision once surgery is performed, if it is even required, and how to look for signs of infection. The infant's response to feeding should also be observed. Vomiting may still be present, however, if it does persist beyond that 48-hour mark, the healthcare provider should be notified. Now we'll look at cleft lip and cleft palate. A cleft is a fissure or elongated opening. A cleft of the lip, palate, or both is one of the most common congenital abnormalities of the infant. When we look at clinical manifestations, the cleft lip can occur as either unilateral or bilateral and can vary from a slight notch in the red portion of the lip to a complete separation extending all the way into the nostril. Cleft palate can occur in the hard or bony palate or in the soft palate, with or without the cleft lip being present. Cleft lip and, in most cases, cleft palate are obvious at birth. Even a small cleft of the palate can be detected by visual inspection and palpation. When cleft palate is not diagnosed at birth, breast milk or formula come from the nose may be the first sign. Both of these defects can be diagnosed in utero by ultrasound, and if present, the family will be referred to a multidisciplinary team at a cleft palate, craniofacial, or orofacial center. Treatment for the child with cleft lip and palate is complex and involves many specialists, including plastic surgeons, your neurosurgeons, orthodontists, your pediatricians, the nurse, the speech pathologist, and so on and so forth. Reconstruction begins in infancy and can continue through adulthood. Wide variations exist in timing and technique. Closure of the lip is usually performed when the infant is approximately 3 months of age or at least 12 pounds. The goal of surgery is to close the cleft so scarring will be minimal and the face will have an increased chance to develop normally. Clefts of the hard or soft palate are surgically closed at approximately 1 year of age to assist feeding and promote speech and language development. When it comes to nursing management for the cleft lip and cleft palate, a cleft of the lip and usually the palate are, of course, able to be seen at birth. During the newborn assessment, the nurse examines and palpates by visualization and using a gloved finger. A description of the location and extent of the deficit should be documented. The neonate's ability to suck, swallow, and feed are also noted. Nurses must also assess the caregiver's reaction at birth of the baby because a cleft lip may be devastating, especially if they did not really know in utero. As far as preoperatively, nursing care focuses on providing support for the caregivers, preventing aspiration and infection, and ensuring adequate nutrition. Caregivers may become preoccupied with the baby's appearance and experience negative feelings toward the infant and may disrupt or delay attachment. Nurses working with these families must realize that these are normal reactions and they can aid in bonding process by demonstrating acceptance of the baby and by encouraging caregivers to hold and touch their infant. Feeding problems such as poor or inadequate suction, prolonged feeding time, frequent nasal regurgitation, and inadequate weight gain can be a frustrating and exhausting experience for many caregivers. Early teaching by nurses about anatomy and functioning of the palate and successful feeding techniques can decrease this anxiety. Breastfeeding of an infant with cleft lip or cleft palate is one option for the mother. The infant with only cleft lip will probably have no more difficulty than any other baby in achieving effective breastfeeding. The breast itself tends to fill the opening of the lip because it has the capacity to mold to the shape of the oral cavity. It may be possible to breastfeed an infant with both cleft lip and cleft palate. However, if this method is unsuccessful, a breast pump may be used to express milk and bottle feed with special nipples that should be used. If the method chosen is bottle feeding, it is important for the caregivers to initially try a regular nipple and bottle, as some infants with small clefts may be feeding satisfactorily without the special adaptations. One method use readily available standard nipples and bottles that is inexpensive and convenient is the enlarged stimulant swallow and breast method. Enlarging the nipple hole, stimulating the infant to suck, allowing them to swallow, and then giving them adequate rest periods has also shown great significance in working for feeding when we're bottle feeding. They also have special nipples for those with cleft lip and cleft palates if they're not able to drink with the regular nipples. So you may see those on the unit. Usually they're in your more specialized units, so you may not see them readily on like a postpartum or baby unit. You may see them in labor and delivery. You may also see them in your NICUs and your pediatric ICUs. The major emphasis of surgery for cleft lip repair is the protection of the operative area. A small metal strip called a Logan bow or butterfly adhesive may be placed over the upper lip and taped to the infant's cheeks to prevent tension on the supine. The infant should be placed only on the back or side opposite of the surgical incision. Arm or elbow restraints are applied to prevent touching or pulling at the site. You do want to look at the nursing tips in your text on page 748 and 749, caring for families whose child has a cleft lip or cleft palate, and also breastfeeding an infant with a cleft lip or palate. Family teaching includes information about feeding techniques and, of course, care of the operative site. Looking at esophageal atresia or tracheoesophageal fistula, they are congenital defects of the esophagus. They can each occur as a single entity, but usually occur together. EA is characterized by an incomplete formation of the esophagus, so it terminates before reaching the stomach. It is usually associated with a fistula between the trachea and the esophagus, known as TEF. Many anatomic variations of EA with or without TEF TEF have been described, illustrated in your text on page 750. Typically, the neonate with EA or TEF presents with copious, fine, frothy bubbles of mucus in the mouth and sometimes the nose. These secretions may clear with aggressive suctioning, but eventually return. The infant may have rattling respirations and episodes of coughing, choking, and cyanosis. These episodes may be exaggerated during feeding. If the fistula between the esophagus and the trachea is present, abdominal distension develops as air builds up to the stomach. A history of maternal polyhydramnios, an excessive amount of amniotic fluid, should suggest the possibility of high gastrointestinal obstruction, which prevents the fetus from swallowing and absorbing the fluid. The inability to identify the fetal stomach bubble on a prenatal sonogram in the mother with polyhydramnios makes the diagnosis for EA more likely. Before the performance of the first successful repair in 1939, this condition was fatal. However, over the past 50 years, refinements in neonatal surgical techniques, preoperative support, anesthesia, and neonatal intensive care have improved the outcome. Treatment is aimed at preventing aspiration pneumonia until surgical repair of the defect is actually completed. Healthy infants without pulmonary complications or other major anomalies usually can undergo surgery within the first few days of life. A type of surgical correction depends on the esophageal abnormality. A one-stage root connect both ends of the esophagus and close the fistula is preferred in all infants with TEF. The goals preoperatively are prevention of aspiration of secretions from the upper esophageal pouch and prevention of regurgitation of stomach contents through the fistula into the trachea. The nurse needs to observe for early signs of airway obstruction, such as anxious expression on the infant's face, tachypnea, and the presence of abnormal breath sounds. When we look at family teaching, the family of infants who require multiple stage surgery need to learn how to perform the necessary procedures for gastronomy feedings and care of oral feedings as well. I want to mention one particular example when we look at cleft lip and cleft palate. If the mom is wondering if breastfeeding is possible because we get this all the time, and I do mean all the time. The parents do not think they can feed the baby just because they have a cleft lip or cleft palate. So if you have an infant with cleft palate and the mom is expressing concern about breastfeeding after the corrective surgery is done, as the nurse, you want to let her know that breastfeeding is likely to be possible, but that she does need to check with the surgeon. So the doctor or healthcare provider will come in and let her know if she can indeed breastfeed or the baby will have to be fed with a special bottle, depending on how severe the cleft lip and cleft palate really is. And like your text said, your infants with cleft lip are able to breastfeed fine, basically, because the lip, even where it's missing, it molds to the mother's breast, whereas your palate, both hard and soft, don't have that ability. So we never want to tell the parent that we're 100% sure they can breastfeed after surgery. We want to tell them that it is most likely possible, but that they need to check with the surgeon. Alright, let's continue on with the lower gastrointestinal alterations. The lower gastrointestinal alterations in infants and children include obstructive disorders in which nutrients and secretions are unable to pass through the GI tract, and elimination disorders. First, we'll talk about intussusception. This is a common pediatric condition that occurs when one segment of the bowel telescopes into the lumen of an adjacent segment of intestine. It is the most frequent cause of intestinal obstruction in infants and young children. 5 signs and symptoms are classical in the infant with intussusception: colic, intermittent abdominal pain, crying while drawing the legs to the abdomen, vomiting, and current jelly-like stools. However, these are present in fewer than half of infants with this disease. Characteristically, a previously healthy, thriving infant has a sudden onset of severe and intermittent abdominal pain. Non-bilious vomiting is the predominant sign in neonates and is usually seen early in the illness. In the later phase, the vomitus becomes bile stained. Blood and mucus appear in the stool, resulting in the red, currant, jelly-like appearance. The abdomen is tender, and the sausage-shaped mass may be felt in the right upper quadrant. As intussusception progresses, the infant becomes listless and lethargic. Eventually, a shock-like state may develop with a weak and thready pulse, shallow respirations, and a marked elevation of body temperature. An X-ray of the abdomen is nonspecific in the diagnosis. However, it will reveal intraperitoneal air if present, which indicates bowel perforation. The definitive test for diagnosing intussusception has been the barium or air contrast enema. Contrast enema is a safer procedure with minimal risk of bowel perforation. Nonetheless, it is invasive and presents the potential risk of radiation exposure. In addition, this test may be unnecessary if a less invasive technique can be used to accurately rule out intussusception. The treatment of choice for this disorder is non-surgical hydrostatic reduction by using barium, a water-soluble contrast agent, or an air enema. The water-soluble contrast and air inhalation, or blowing air into a cavity, are believed to be safer than the barium, with less risk of bowel perforation. Successful reduction rates have been reported as high as 90% for air and 65 to 85% for barium or water-soluble contrast agents. Because the onset of this disorder is so abrupt, most caregivers need much reassurance regarding the effectiveness of treating excellent prognosis. Preparation for hydrostatic reduction involves placing the infant on NPO status, inserting an NG tube that is connected to low suction, and administering IV fluids. The nurse monitors the infant's vital signs and mental status for changes that might indicate perforation, peritonitis, or shock, assesses for worsening abdominal pain, and examines and records all stools. When the child is discharged, the nurse should instruct the caregiver to observe signs of intestinal obstruction and reoccurrence. These include increasing abdominal pain, abdominal distension, blood in the stools, bowel stain, vomiting, and decreased or absent stools, all of which should be reported to their healthcare provider. Looking at Hirschsprung's disease, or HD, also called congenital agangliotic megacolon, is a motility disorder of the bowel caused by an absence of parasympathetic ganglion cells in the large intestine. This absence prevents peristalsis and causes feces to accumulate proximal to the defect, leading to bowel obstruction. It is the most common cause of distal bowel obstruction in the newborn. However, it may not be diagnosed until infancy or even childhood. In the newborn, the primary manifestations are failure to pass meconium, usually that first feces of the newborn within 24 hours to 48 hours after birth, abdominal distension, bile stain vomitus, refusal to feed, and intestinal obstruction. In older infants and children, the initial symptom is chronic constipation. Abdominal distension, episodes of explosive passage of stools, inadequate weighing, ribbon-like or pellet-shaped, foul-smelling stools, vomitus, and easily palpable fecal mass may also be present. The most ominous complication is enterocolitis, inflammation of the small intestine, and the colon. An otherwise well infant who has a history of constipation has an abrupt onset of foul-smelling diarrhea, abdominal distension, and fever. The illness may progress rapidly with perforation of the bowel and sepsis, and may occur before, during, or after surgery. Enterocolitis and sepsis remain the most serious complications and major causes of death, with Crohn's disease occurring in about 30% of the cases. The abnormal section of the colon must be surgically removed when we look at treatment. The surgical treatment is usually performed as a two-stage procedure. In the first stage, a temporary colostomy is created in the normal bowel. The purpose of the colostomy is to provide a means for the infant to defecate, to allow the bowel to rest, and the infant to gain weight. The second stage involves a pull-through procedure in which the affected aganglionic segment is restricted or removed, and normal bowel is anastomied to the rectum. The temporary colostomy is also closed at this time. The definitive surgical repair is performed when the infant reaches 6 months of age or weighs 20 pounds. When we look at nursing management, preoperative assessment of the infant's fluid and electrolyte status is essential because preparation for surgery involves extensive bowel cleansing with repeated saline enemas. The infant is NPO and an NG tube needs to be inserted. IV fluids and electrolytes are administered to prevent dehydration and correct electrolyte deficiencies as they occur. Oral administration of antibiotics may be ordered in conjunction with antibiotic enemas to reduce intestinal flora. When we look at family teaching, the nurse explains to the caregivers about the need for surgery and the temporary colostomy and how to care for it. Instructions include skin care, application of the appliance, and information about community resources for obtaining supplies. When we look at anorectal malformations, anorectal malformations are defined as an arrest of rectal descent resulting in absence of an anal opening and occur during the 4th and 16th of gestation. These are usually obvious at birth. Low defects vary from normal appearing anus to a thin translucent anal membrane to a deep anal dimple. In high D, the anal dimple will demonstrate strong muscular contractions when pricked by a pin. High defects with a flat perineum, absence of an anal dimple, and muscular contraction to a pinprick. If meconium is noted in the urine, a fistula is present between the bowel and the urinary tract. Fistulas can also be present between the bowel and the vagina in females. Diagnosis is made by physical exam and by radiologic imaging of the abdomen. Treatment depends on the extent of the malformation. Anal stenosis is managed with repeated manual dilation of the anus. All other defects require surgery. When we look at nursing management, during the newborn examination, the nurse assesses the patency of the anus by inserting a rectal thermometer. The defect is obvious when there is absence of a normal anal opening. When we look at family teaching, caregivers are instructed in colostomy care, perineal wound care, and anal dilations as appropriate. Prevention of constipation is stressed in family education. Adequate fluid, dietary fiber, and stool softeners or bulk agents help the child to achieve normal bowel activity. Now we'll look at alterations in motility. And this will lead us to our gastroesophageal reflux, or what you guys remember as GERD. And I know you probably think about it as GERD, but it is actually just gastroesophageal reflux. Gastroesophageal reflux is the most common esophageal disorder in infants, and the condition most frequently referred to a pediatric gastroenterologist. It is defined as return of gastric contents into the lower esophagus through the lower esophageal sphincter. When we look at clinical manifestations, vomiting and regurgitation are the most common symptoms. The regurgitated matter is typically non-bilious and consists of undigested formula and mucus. Diagnosis is established by taking a history, performing a physical exam, observing the infant's feeding habits, and conducting several diagnostic tests. The first goal is to rule out other possible causes for symptoms such as gastrointestinal tract obstructions, neurologic disease, and metabolic disorders. Several diagnostic tests exist to help confirm GERD, including an upper GI barium series that is performed to eliminate anatomic abnormalities from the consideration. When we look at treatment, medical management involves dietary modifications, positioning, tobacco smoke avoidance, and, of course, medications. Non-pharmacologic therapies are beneficial to infants with GERD. Small, frequent feedings are recommended because of the probable relationship between gastric volume and reflux. Most of the SIDS deaths in the prone position are attributable to suffocation because of the puffy bed materials such as comforters. If these materials are eliminated from the infant's bed, the superiority of the prone position for GERD is clear and has been recommended by the AAP. So basically what your text is relaying to you is that it is okay to place the child in the prone position if they do not have anything in the bed. And this is only if they have GERD. The two PPIs, or proton pump inhibitors, that are approved for pediatric use is Prevacid and Prilosec. The use of antacids in pediatric GERD is generally not recommended. The prokinetic metoclopramide, or Reglan, is used to improve gastric emptying and esophageal motor tone, but to date there are no studies supporting its use in managing the symptoms of GERD in infants and children. When we look at planning and implementation, if the healthcare provider has recommended the head elevated prone position after feedings and during sleep, maintaining this can be challenging for caregivers. This position can be achieved by using a wedge, sling, harness, and towel rolls, some of which are commercially available. Now we'll look at constipation. Of course, this is the difficult passage of stool or infrequent passage of hard stool associated with straining, abdominal pain, or withholding behaviors for more than 2 weeks. The child who is constipated will have to work hard. They will have hard, small stools that may be passed at regular intervals, or large, massive stools at intervals of days to weeks. Soiling of underwear in the child who is toilet trained is also possible. Abdominal pain or distension develops as more stool accumulates in the bowel. The child often cries during toilet time. The child may become irritable and experience a loss of appetite. Often a palpable fecal mass is felt on the physical exam. Diagnosis is actually based on history and physical. When attempting to determine the cause, it is more important to rule out any organic causes. A thorough dietary history is also obtained. A description of stool patterns, such as frequency, consistency, and size of stools, and toilet training history is elicited. Constipation is treated with a combination of therapies, which include cleansing the bowel, establishing a regular pattern of defecation, and modifying the diet. Modification of the diet includes increasing intake of fiber and fluids. Establishing a regular pattern for defecation is largely a matter of caregiver education about normal defecation and bowel training techniques. Nursing intervention here focuses solely on education. Dietary modifications include increasing dietary fiber and fluids. The nurse should teach the caregivers about high fiber foods and diet planning. Establishing a regular pattern of defecation is accomplished by requiring the child to sit on the toilet after a meal for a reasonable amount of time, such as 5 to 10 minutes. Positive reinforcement with star charts or small prizes can be used to reward success and adherence with toilet scheduling and taking medications. The family needs to understand the causes of constipation to be compliant with the treatment plan. Parents often continue to blame behavioral aspects on fecal soiling. These include laziness, carelessness, and emotional problems. The nurse needs to educate the family that this is often not the cause. Emotional support to the child is also essential. Denial of fecal soiling is common in children. Shame and fear of punishment may contribute to this denial. Now we'll look at a few inflammatory disorders. The first one is appendicitis. This is the inflammation of the variform appendix, or the small sac at the end of the cecum. It is the most common condition requiring abdominal surgery in children. Appendicitis is the most common condition requiring surgery in childhood, occurring at a rate of 4 per 1,000 children younger than 14 years of age. When we look at clinical manifestations, abdominal pain is usually the first symptom in typical cases of appendicitis. Initially, the pain may be vague and poorly localized to the periumbilical area, gradually migrating to the right lower quadrant. Anorexia and nausea, with or without vomiting, may also be present, but occur after the initial symptom of pain. The most reliable information gained from the history is the sequence of symptoms. Pain nearly always precedes anorexia, nausea, or vomiting. Nausea and vomiting that precede abdominal pain often indicate gastroenteritis. I want you to look at the nursing tips in your text on page 760 and 761 that go over palpating the abdomen, assessing for appendicitis, and assessment of peritoneal irritation. When we look at diagnosing, appendicitis remains a diagnosis made largely on the basis of the history and physical exam. Tenseness of the muscles or muscle rigidity over the tender area may be felt. Rigidity over the entire abdomen, accompanied by tense positioning and guarding of the abdominal muscles, indicates perforated appendix with peritonitis. Rebound tenderness describes a sensation of severe pain that occurs after deep pressure is applied and released and is indicative of peritonitis. Laboratory findings do not establish the diagnosis, but there is often a moderate elevation of the WBCs, seldom higher than 15 to 20,000, with a shift to the left. However, note that some children with appendicitis have normal white blood cell counts. Delay in diagnosing appendicitis in children is a factor contributing to perforation in about 30 to 60%. Complications of perforation are major abscess, phlegm, intercutaneous fistulas, peritonitis, and partial bowel obstructions. When we look at treatment, once the diagnosis of appendicitis has been made, surgery is required as soon as possible. In an uncomplicated open appendectomy, an incision approximately 2 to 3 inches is made in the right lower quadrant. If perforation is suspected or has occurred, or the appendix is in an atypical position, the incision will be quite larger. Additional treatment includes IV antibiotics for 7 to 10 days, NPO status, NG tube suctioning, IV fluids, and pain medication. The child remains NPO until bowel function returns and is discharged when wound drainage is minimal and oral intake is satisfactory. Now we'll look at IBD, or inflammatory bowel disease. This refers to a group of chronic disorders that cause inflammation or ulcerations in the small and large intestine. These include ulcerative colitis, or UC, and Crohn's disease, which is CD. Ulcerative colitis involves inflammation of the mucosa and submucosa of the colon and rectum, while CD, or Crohn's disease, is an inflammation that may involve the entire gastrointestinal tract and all layers of the bowel wall. When we look at clinical manifestations of these, the most common symptoms for ulcerative colitis are rectal bleeding, diarrhea, and abdominal pain. Multiple patterns of presentation occur in children and adolescents. Mild disease is seen in about 50 to 60% of cases. The onset of diarrhea is insidious, and there is no extraintestinal or systemic signs of fever, weight loss, or hypoalbuminemia. 30% present with moderate disease characterized by bloody diarrhea, abdominal cramping and tenderness, and the urgency to defecate. In contrast to ulcerative colitis, Crohn's disease may occur in any segment of the gastrointestinal tract, and the clinical manifestations are determined primarily by the location and extent of the disease involvement. The majority of children, which is 50 to 70%, have disease involving the terminal ileum. In these children, symptoms of malabsorption predominate, including diarrhea, abdominal pain, anorexia, weight loss, and growth failure. Presenting symptoms and clinical course of UC and CD are similar enough that they often elude a differential diagnosis, sometimes for years. Diagnosis is based on history and physical exam and endoscopic or radiologic examination of the colon to evaluate the character and location of lesions. Treatment for inflammatory bowel disease includes or involves pharmacologic, nutritional, and surgical approaches. The goals include controlling the disease, inducing remission, and preventing relapses, providing adequate nutrition for growth and development, and assisting the child to function as normally as possible. Pharmacotherapy is aimed at either decreasing inflammation or directing suppressing the immune system. The goal of nutritional support is to replace lost nutrients and to provide adequate caloric intake for growth and normal metabolic functions. While there is no special diet that has been proven effective for treating IBD, some individuals find their symptoms are aggravated by milk, highly seasoned foods, and fiber. The focus of nursing care includes medication and nutritional management, emotional support, and community referrals. An area for potential strife between the child and the caregivers is usually the medication regimen. The nurse can provide information about medications used to treat IBD and their side effects, emphasizing that they need to be continued despite the remissions of symptoms, and this can sometimes be hard for kids to understand. So, of course, you want to provide as much emotional support and education as possible. I do want you guys to look at the comparison table 23-1 in your text on 766 that goes over ulcerative colitis and Crohn's disease. I also want you to look at the family teaching on 767, which goes over inflammatory bowel disease. We will skip over peptic ulcers, and I will finish up with necrotizing enterocolitis, or NEC. This is a life-threatening condition in preterm neonates, so you may see these in the NICU. And yeah, you'll see them primarily in the NICU because it's for the neonates, not so much for the pediatric patient. It is characterized by necrosis of the mucosa of the small and large intestines, frequently the distal ileum and proximal colon. It is the most common surgical emergency in this age group. The necrosis may be very superficial and only detectable microscopically, or it may be through the bowel wall. Mild disease may be completely reversible, but neonates with extensive involvement may not survive. It commonly occurs in preterm, low birth weight neonates and is rarely seen in term infants. It appears to occur in the preterm neonates whose bowel has experienced an injury resulting in vascular compromise. This leads to decreased blood flow to the bowel and ischemia of the intestinal mucosa. The classic clinical presentation of the neonate with NEC or NEC includes the symptom group of abdominal tenderness, distension, and erythema of the abdominal wall, bloody stools, decreased bowel sounds, increased gastric residuals, and bilious vomiting after feeding. Manifestations of clinical deterioration include apnea, bradycardia, lethargy, temperature instability, decreased urine output, further abdominal distension, and evidence of shock. Note that hypotension is a late sign of deterioration. Acidosis, sepsis, and death may occur if NEC is not properly treated. Diagnosis is based on clinical findings and abdominal x-rays. Radiographic findings associated with NEC are dilated bowel loops and pneumatosis intestinalis. If NEC is diagnosed in its early stages and treatment is initiated promptly to prevent perforation, the infant may improve without surgical intervention. Initial treatment includes cessation of oral feedings, continuous gastric drainage, and decompression of via NG tube. Maintenance of oxygenation, ventilation if necessary. Administration of IV fluid therapy for parenteral nutrition, and broad-spectrum antibiotics and restore the acid-base and electrolyte balance. Administration of probiotics and prebiotics are also necessary. When we look at nursing management, the nurse has a major responsibility to be aware of and continually assess for early warning signs of NEC. Frequent measurement of abdominal girth is performed to assess for distension. Prior to feedings, gastric residual contents are measured to determine if the volume is increasing, which indicates malabsorption. The presence of bowel sounds is also noted to evaluate for decreased intestinal activity, and all stools are tested for blood. When NEC is diagnosed, nursing interventions include accurate intake and output measurements, frequent assessment of vital signs, maintenance of IV therapy, and ongoing assessment for changes in the infant's conditions. I do want you guys to take a look at the nursing alert in your text on page 770 that goes over the warning signs of necrotizing enterocolitis. Now, when you are teaching about, let's say, enemas, you want to make sure the parents know that they will only use about 500 to 1,000 mLs for the child. If you got the regular enema bottles out of the store, you may note that they are more than 1,000 cc's. For the child, we want to only use 500 to 1,000, and most oftentimes they do sell them for the pediatric patient. So you want to note that you get the proper one and not get the wrong one for an adult, because we do not want to give too much to the actual child. Also, IBS characteristics would include most common between the ages of 10 and 20 years. So these are characteristics that you will notice for IBD patients. It is common between the ages of 10 and 20, elevated erythrocyte sedimentation rates, and low serum iron levels. When we look at Crohn's disease, when conducting a physical exam, the nurse would suspect Crohn's disease if you saw perianal skin tags or fissures. That would be one characteristic that would suspect you to rule out Crohn's disease. Also, note if you are educating about gallbladder disease, students would need further teaching if they stated to you that cholesterol gallstones are more frequently found in males. This is not true. Why do you think it's not true, though? Gallstones are frequently found in females, but they have an incidence to be found in both. And that is because of the fatty content and the diet that is usually being absorbed by both the female and the male. So it is not really higher in one species over the other, or gender, shall I say, but that would require them to have further teaching when we talk about gallstones and cholesterol. Alright, let's look at some of the malabsorption alterations. Malabsorption occurs when there is a disruption in the digestive process causing insufficient accumulation or assimilation of nutrients. Common causes of problems in absorption in infants and children that will be discussed is celiac disease and, of course, lactose intolerance. When we look at celiac disease, it is also known as gluten-sensitive enteropathy, and it is a disorder caused by permanent intolerance to gluten, the protein component in wheat, barley, rye, and oats. It is second only to cystic fibrosis as the most common cause of malabsorption in children. Early clinical manifestations of celiac disease are subtle, and include anorexia, irritability, listlessness, and weight loss. As the disease progresses, abdominal distension and chronic diarrhea appear with large amounts of unabsorbed fats being excreted in the stools, also known as stearia. The stools are bulky, putty-colored, foul-smelling, greasy, and often float because of the high fat content. Signs of progression include a protuberant abdomen of subcutaneous fat and muscle wasting secondary to hypoproteinemia. The child may appear pale because of anemia, and bruising may develop secondary to inadequate vitamin K absorption. Late signs include severe growth retardation, osteoporosis, and in adolescence, delayed menses or puberty. Serologic tests to detect IgA, anti-TTG, is commonly ordered. The immunofluorescence IgA EMA test has equivalent diagnostic accuracy and is slightly more specific. Medical management consists of lifelong adherence to a gluten-free diet. Education about the diet is the main goal of treatment and involves the healthcare provider, nurse, dietitian, caregivers, and other family members, as well as the child. All wheat, barley, rye, and oats are eliminated and substituted with rice, corn, and millet. Specific nutritional supplements may be used to correct deficiency states. The most common are supplements of iron, folate, calcium, and fat-soluble vitamins. The intolerance of gluten is permanent, and the lack of adherence to a gluten-free diet can cause exacerbation of symptoms. Gluten avoidance is almost impossible in the American food industry, and even tiny amounts of gluten can cause symptoms. A long-term goal of nursing care is to provide dietary education and supervision. A dietitian should be involved in diet planning and nutritional education and serves as a resource for gluten-free foods and recipes. Fats used to fry foods may contain gluten, and families must be cautious when consuming fast foods. Children and their families often react to the necessity of a gluten-free diet with grief and may have a hard time accepting that something so fundamental to their diet could be injuring their child. Caregivers should be forewarned that many adolescents specifically have a difficult time accepting the dietary restrictions and may experiment with foods containing gluten. They may be motivated to adhere to restrictions by the exception of dramatic improvements in gastrointestinal symptoms such as bloating, abdominal pain, and diarrhea, and in their general well-being. I want you guys to review lactose intolerance. It's pretty self-explanatory. And also poisoning, which is found in your text starting on page 772, and it leads over into 773. I specifically want you to look at gastric lavage and activated charcoal, as well as the antidotes, and these can be found in your text on page 774. You can also refer to the table 23-4, which talks about clinical manifestations of commonly ingested poisonous substances. We will very quickly look at lead poisoning before we move on to hepatic alterations. So that your lead poisoning is defined as a blood lead level, or BLL, of 10 micrograms per deciliter and above. Even though the median BLL in children less than 5 years of age have declined 89% from 1976 to 1980, children continue to be exposed to lead, and it is still a major environmental health problem that could harm their health and impair their ability to learn. And this usually affects the kids that are in those homes built prior to 1980. So your 1950s, 1960s homes that were built, they used lead-based paint, and I am almost 100% sure that they should have stopped selling lead-based paint because of the defects and the problems that they have seen. Now we will go on to hepatic alterations, which talks a little bit about hepatitis. I'm not going to go into all of the hepatitis A, B, and C. I do want you to read over the incidents for those, but I also want you to look at the risk factors that are located in your nursing alerts on page 776, which talks about risk factors for hepatitis A and B. Also, pay close attention to the box 23-3 that talks about poison prevention guidelines. These are helpful things for the parents and caregivers to know when we are educating them on poisoning. So looking at our hepatic alterations, hepatitis is an acute or chronic inflammation of the liver caused by several viral or bacterial infections, fungal or parasitic infections, or chemical and drug toxicity. 5 distinct viruses have been identified as causing hepatitis. We have the hepatitis A virus, B virus, C virus, D, and E. In this section, A, B, and C will be discussed because hepatitis D and E are very uncommon in children. So hepatitis A causes only acute hepatitis, whereas B and C cause chronic infections. Hepatitis viruses are classified as enteral or parental, and in reference to their mode of transmission. So, like I said before, go ahead and review the incidence and etiology of A, B, and C, as well as the pathophysiology. And we will go over to the clinical manifestations found in your text on page 777. The manifestations of viral hepatitis are similar. Generally, children have mild, nonspecific symptoms without jaundice or are asymptomatic altogether. Initially, the child experiences nausea, vomiting, anorexia, slight fever, fatigue, headache, and abdominal pain in the epigastrium or upper right quadrant. These flu-like symptoms last approximately 1 week and may be so mild that they go unnoticed in infants and young children. Following this period, jaundice may develop, beginning with darkening of the urine and gray-colored stools, followed by yellowing of the skin and sclera. However, many children with acute hepatitis never develop jaundice. The liver usually is enlarged and tender to palpation. With hepatitis B and C may also present with dermatologic symptoms such as rashes and pruritus or severe itching. You want to review the table 23-5, which is found in your text on page 778, that goes over hepatitis A, B, and C. And one little example that I do want to point out and take you back to celiac disease, because these people are needing a gluten-free diet, appropriate foods for children with this disease, you could tell them jelly, peanut butter, shellfish, and carbonated drinks. Although we want to limit the carbonated drinks for our children, those are okay for them to have. Lastly, we will quickly look at additional gastrointestinal disorders. The first one is abdominal wall defects, or your gastroenteritis, or omphalocele. These are congenital abdominal wall defects that result in herniation of the peritoneal contents through the abdominal wall with omphalocele or without gastroenteritis, a membranous cover. An omphalocele is centrally located, includes umbilical cord and the abdominal viscera, and is covered by a protective sac, whereas your omphalocele results from failure of the intestines to re-enter the abdominal cavity at approximately the 7th week of gestation. The size of the defect is variable, ranging from 1 centimeter in diameter to a large mass containing all abdominal wall contents. In gastritis, the bowel eviscerates into the amniotic cavity, and exposure to the amniotic fluid result in thickened, beefy red edematous intestines. The bowel is normal in appearance in the neonate with omphalocele. However, the abdominal cavity is small and underdeveloped. Goals of initial management of the newborn with either of these disorders to prevent hypothermia, maintain sterile environment, and maintain tissue perfusion. Two accepted surgical techniques for these defects are a primary and a staged repair. The primary repair is the procedure of choice if the exposure of the abdominal contents will fit into the abdominal cavity. If not, a staged repair is performed. A synthetic material is used to create a sac to cover the abdominal contents. The bowel is then gradually returned to the abdomen over the course of 7 to 10 days. The abdominal wall is closed in the second surgery. Now looking at biliary atresia. This is characterized by a congenital absence or obstruction of the bile ducts outside the liver, thus preventing flow of bile from the liver to the intestines. There is no known cure for this disease. The newborn with biliary atresia is asymptomatic at birth. However, between 2 weeks and 2 months of age, jaundice appears. The infant's urine is tea-colored because of the excretion of bilirubin and bile salts. Stools are light in color because of the absence of bile pigments, and hepatomegaly may be present from the pathologic process occurring, such as fibrosis of the liver, failure to thrive, and malnutrition eventually develop. Treatment involves surgery to correct the obstruction and allow for drainage of the bile from the liver directly into the intestines. Complications of liver disease continue to develop and eventually result in end-stage liver disease. A liver transplant is at this point. Parents and siblings or close relatives may donate a portion of their liver to the child. When we look at cirrhosis, cirrhosis is a pathologic condition of the liver that occurs secondary to the liver disease or inflammation. Viral hepatitis, inborn errors of metabolism, congenital anomalies of bile ducts, and chronic disease such as cystic fibrosis are the main disorders that cause severe liver disease and cirrhosis in infants and children. Cirrhosis is rare in the pediatric population. Clinical manifestations vary depending on the cause of the cirrhosis. When the etiology is viral hepatitis, inborn errors of metabolism, and chronic disease, initially the child demonstrates vague symptoms of GI dysfunctioning, lethargy, anorexia, and nausea. Steatorrhea is frequently present, caused by disordered fat metabolism. In cases caused by biliary anomalies, ascites, and portal hypertension may develop. Medical management focuses on preventing and treating the complications of cirrhosis. Nutritional treatment malabsorption problems consist of a low-fat, low-protein diet and supplemental vitamins, especially the fat-soluble ones. Now looking at umbilical hernias. This results from incomplete closure of the umbilical ring, which allows the intestines to protrude through the defect, especially during crying or straining. It is most common in African American low birth weight females. The size of the defect varies from less than 1 centimeter in diameter to as much as 5 centimeters. The use of binders, tape, or other materials to flatten the protrusion do not aid in closing the defect. Most umbilical hernias disappear spontaneously by 1 to 3 years of age. If the hernia persists beyond this age, it becomes strangulated, or if it grows larger, it needs to be surgically corrected. Now looking at congenital diaphragmatic hernia, or CDH. This involves herniation of the abdominal contents through a defect in the diaphragm into the chest cavity and usually develops on the left side. Separation of the developing thoracic and abdominal cavities is accomplished during the 8th week of gestation by closure of the pleural peritoneal canal. CDH occurs when this canal fails to close. Newborns will have severe respiratory distress, cyanosis, tachypnea, and retractions at birth because the lung on the side that the defect is happening is usually hypoplastic or underdeveloped. Breath sounds are decreased or absent on the affected side, and the chest is barrel-shaped. Heart sounds are shifted to the right. Bowel sounds may be heard over the chest. The abdomen will also be scaphoid. The mortality rate is high despite advances in current treatments. Some fetuses are diagnosed prenatally by ultrasound, in which case surgical repair is performed in utero. If not diagnosed and repaired at this time, the newborn is stabilized before surgery. Ventilatory support is required to manage respiratory compromise. Metabolic acidosis is corrected with the administration of bicarbonate. If stabilization is not possible, extracorporeal membrane oxygenation is required in most cases. The surgery involves repositioning the abdominal contents into the abdomen and closing the defect. I want you guys to briefly review malrotation and volvulus, as well as Meckel's diverticulum, and short bowel syndrome is the last thing that we will cover. And briefly, Short bowel syndrome is a disorder characterized by inadequate surface area of the intestine and usually occurs after surgical resection of the intestine in cases of necrotizing enterocolitis, volvulus, or Crohn's disease. The small intestine may be congenitally short in conditions such as gastriticis, omphalocele, and intestinal atresia. The most common clinical manifestations are malabsorption, malnutrition, and diarrhea. Carbohydrate malabsorption and stearia are also occurring during this disorder. Fluid and electrolyte losses may lead to dehydration, hyponatremia, hypokalemia, and acidosis. The medical management for short bowel syndrome focuses on maintaining optimal nutrition and preventing complications. Nutritional therapy includes total parental nutrition or TPN via central and integral feedings via an NG tube or gastrostomy tube. The main purpose of enteral nutrition is to stimulate the adequate growth of the small intestines. Oral feedings are given when tolerated so the infant can learn to suck and swallow. Additionally, to maintain an interest in oral feeding and to stimulate sucking, a pacifier may also be used. When enteral and oral feedings are increased, TPN is gradually decreased proportionally. And with that being said, that will end our chapter 23, which goes over GI or gastrointestinal alterations. Alright, we will look at the last chapter here, which is chapter 28, that will review endocrine alterations. Please go ahead and review your anatomy and physiology. And this all starts on page 984 in your text. And we will go ahead and look at the disorders of the anterior pituitary. Now, I do want you to pay close attention to note that your A&P also goes over the A&P of the different glands. Your pituitary gland, thyroid, parathyroid, adrenal glands, and also the pancreas, which will then lead us into the disorders of the anterior pituitary. The first one we will look at is the growth hormone deficiency, or GHD. This is characterized by primarily by poor growth and short stature caused by failure of the pituitary to produce sufficient growth hormone. This plays a primary role in postnatal growth. It is released in the postural or pulsating fashion throughout the day. However, most is secreted primarily after the onset of sleep. Hence why when the infants are sleeping so much, we're saying they're growing. When we look at clinical manifestations, the child with GHD presents with a short stature and is deteriorating less than 4 to 5 centimeters a year or absent rate of growth. Children with GHD tend to have higher weight to height ratio and delayed bone age. A determination of skeletal maturation by X-ray of the hand, wrist, or knee. Additional clinical manifestations include increased fat in the trunk area, childlike face with a large prominent forehead, high-pitched voice, hypoglycemia, micropenis and small testes in males, delayed sexual maturation, and delayed dentition. The growth concern is typically identified by the family or primary care provider in an outpatient setting. A clinician who carefully and consistently plots the growth of the child on the standardized growth chart will note the deteriorating rate of growth. Diagnostic workup includes a review of previous growth records, determination of growth rate, radiographic bone studies, MRI, and baseline blood testing. The goal of treatment is to promote normal growth rates by the administration of growth hormone. It is administered as a subcutaneous injection, typically 6 to 7 days each week, at a dose of 0.15 to 0.35 milligrams per kilogram per week in divided doses for children up to 0.7 milligrams per kilogram per week in doses for the adolescent. Response to therapy is more pronounced in the younger child as compared to the adolescent, in the more obese child compared to the thinner individual, and in the more severely growth hormone deficient child compared to one with partial growth hormone deficiencies. This may or may not persist into adulthood. After the child has obtained adult height, with closure of the epiphyseal growth plates, the growth hormone is then discontinued for several months. Rescreening is then done for the adult growth hormone deficiency. When we look at family teaching, because the treatment can continue for many, many years, the nurse needs to prepare the child and the family about the issue before the actual therapy begins. Now we'll look at pre-precocious puberty or precocious puberty. This is defining Caucasian girls as breast development before the age of 7 to 8 and before 6 to 7 in African Americans, and boys less than 9, the onset of testicular enlargement or precocious puberty. This is precocious puberty. I want to note that true or central precocious puberty can be distinguished from precocious pseudo-puberty. True precocious puberty results from premature activation of the hypothalamic gonadal axis, with your GnRH, LH, and FSH and estrogen or testosterone produced. Precocious pseudo-puberty occurs when there is evidence of secondary sexual characteristics such as your breast or sexual hair growth, but no activity or activation of the actual axis. When we look at clinical manifestations, the child with precocious puberty will have an accelerated growth rate, an advanced bone age, evidence of secondary sexual characteristics, acne, an adult body odor, and sometimes behavioral changes. Psychosocial development is typically age appropriate and not a reflection of the physical maturation. Inappropriate sexual behavior is not commonly observed in children with precocious puberty. However, emotional lability or lability, aggressive behavior, and mood swings may occur. The diagnosis of precocious puberty is based on a complete history, which includes a review of the linear growth chart to identify when growth acceleration was evident, exposure of exogenous hormones, CNS trauma or infection, and family history and pubertal development. The physical exam should include a precise description of the child's pubertal status. The child will need screening for labs such as LH, FSH, estradiol, or testosterone. Because these are secreted in puberty in a pulsatile fashion, the levels of these hormones are most elevated at night. First morning labs are done to be most accurately capturing the peak of these levels. Treatment initially focuses on the underlying cause of sexual precocity. In case of a CNS tumor, surgery, radiation, or chemotherapy is usually indicated. Precocious puberty itself is treated with the GnRH analogs. When GnRH analog is initially given, it will stimulate gonadotropin release. When given on a long-term basis, it will suppress gonadotropin release. The GnRH analog is available as a depot injection given every 3 to 4 weeks, subcutaneous injection given daily, and intraspinal compound given 2 to 3 times each day, or hysterine implant. Treatment results in a decrease in growth rate, usually to an age-appropriate level. Now we'll look at disorder of the posterior pituitary, and these are related to deficiency or excess of vasopressin or antidiuretic hormone, your ADH. Diabetes insipidus is one of these disorders. So your diabetes insipidus or neurogenic diabetes insipidus is a disorder of water regulation. The function of antidiuretic hormone is to concentrate urine stimulating reabsorption of water in the renal collecting tubules. The deficiency of ADH results in excretion of large amounts of dilute urine. It is most often seen in children with a complication following head trauma or cranial surgery to remove tumors of the hypothalamic pituitary region. It develops after surgery. It may be persistent or transient or permanent. Other causes include vascular anomalies, which is your cerebral aneurysms, infections such as encephalitis or meningitis, and genetic defects in the synthesis of ATH. In infants, failure to thrive, a history of fevers, vomiting, constipation, dehydration, and poor growth rates are the initial clinical manifestations. In the older child, polyuria and polydipsia are the most common first symptoms. Children experience nocturnal enuresis, which interrupts their sleep and increase thirst. Urine output can range from a few liters to 18 liters a day. An initial screen, rather than a full workup, is valuable in the child who presents with a history that suggests DI. An outpatient screening includes obtaining a first morning urine sample for osmolality, specific gravity, and sodium after attempting an overnight fast. Note that caution should be exercised in instructing the caregivers to do an overnight fast, in that the child with DI can become hypernatremic if fluids are discontinued. A child with hypernatremia is at risk for seizures. If the history of the child strongly suggests that the child has DI, an overnight fast should not be conducted. The child who does have an outpatient screening should be evaluated for hydration status, which includes a weight before the fast has been terminated. Treatment: as long as the child has a normal thirst drive and free access to water, treating DI is not necessary to maintain life. Treatment, however, greatly improves the quality of life because of the inconvenience of polyuria and polydipsia. I do want you to look at the nursing alerts or nursing tips in your text on page 991, which goes over the symptoms of DI. And we want to note that the usual treatment is daily replacement of the hormone ADH, and the drug of choice is desmopressin acetate, which is a long-acting vasopressin analog, which is given intranasally or orally. When we look at nursing management, children with a damaged thirst center provide a special challenge to both the health care providers and the families. Fluid intake regimens will need to be devised, and the family will need to carefully monitor their child's fluid status by measuring intake and output, and also daily weights. For a child who is NPO, pre or post surgery with DI will require careful titration of medication, fluid volumes, and concentration. Frequent electrolytes, ionodes, and reassessment of fluid management plans are necessary. Now we'll look at disorders of the thyroid gland. The first one is congenital hypothyroidism. This is a disorder present at birth. It is a reduced rate of metabolism caused by a low concentration of circulating thyroid hormones, your T3 and T4. The early detection and treatment of hypothyroidism can prevent cretinism or severe mental retardation. When we look at clinical manifestations, the majority of the affected infants are asymptomatic at birth. The most common neonatal clinical sign is a large posterior fontanelle, an umbilical hernia, constipation, and prolonged jaundice. Other clinical manifestations may include pallor, hypothermia, enlarged tongue, hypotonia, hypoactivity, feeding difficulties, delayed mental responsiveness, cool, dry, scaly skin, and swollen eyelids. When we are diagnosing, mandatory newborn screening identifies the majority of newborns with CH and allows early treatment, thereby reducing the incidence of mental retardation. When we look at mentor, thyroid hormone is vital to growing, developing central nervous system. A delay in treatment is associated with lower mean intelligence quotients, or your IQ. Thyroid replacement with sodium L-thyroxine or your Synthroid is initiated as soon as possible with the recommended starting dose of 10 to 15 milligrams per kilogram per day. Given in the psychological doses, the medication does not have any side effects. When we look at nursing management, the child's growth should be accurately measured and plotted on the standard growth chart at regular intervals, often corresponding with visits during which the lab values are obtained. Lab tests are performed initially every 2 to 4 weeks until the thyroid function is within the target range on the stabilized dose medication. Tests will be performed every 3 to 4 months for the first several years of life, with the interval lengthening as the child grows older to every 6 to 12 months in the adolescent period. When we're looking at family teaching, L-thyroxine is an oral medication and is available only as a pill. L-thyroxine should never be given in a compounded liquid form. Caregivers will need to be instructed in the preparation and administration of the pill, which must be crushed for infants and children. The preferred method involves crushing the pill, mixing the powder with a drop of formula or breast milk, placing the paste on the infant's tongue, and then feeding the infant. Teach caregivers about the need to continue thyroid hormone replacement for the child's life. They also need to be prepared for the importance of frequent blood tests for ongoing evaluation of thyroid function. I also want you to look at the nursing tip in your text on page 993, which goes over the absorption of L-thyroxine. Now we'll look at acquired hypothyroidism. This is recognized after the age of 2 and is a condition in which there is inadequate thyroid hormones. When we look at clinical manifestation, the child may present with complaints of fatigue, weakness, constipation, and dry skin. Some children will present with a goiter, which is that enlargement of the thyroid gland. The diagnostic evaluation for primary acquired hypothyroidism is relatively simple, requiring serum thyroid function studies, your TSH, T4, and free T4. Confirmation of autoimmune thyroiditis is made with serum thyroid antibodies. Treatment involves replacing the thyroid hormones with L-thyroxine with a dosage based on the weight of the child and severity of the hypothyroidism. I want you to look at the box in your text on page 994, box 28-2, which goes over the clinical manifestations of acquired hypothyroidism. And lastly, we will look at hyperthyroidism, or hyperfunction of the thyroid gland, which is characterized by excessive levels of circulating thyroid hormones. Initially, symptoms may be mild and easily overlooked by the child's family. Box 28-3, which is found in your text on page 997, and include ophthalmic changes, which is also in box 28-4 on page 997 in your text. Growth patterns may include increased growth velocity, rapidly advancing bone age, and decreasing weight. The diagnosis is confirmed with the serum thyroid testing. Treating Graves' disease is difficult because of the chronic nature of the disorder and because of the treatment options. They all have disadvantages. Current treatment options include anti-thyroid medication, radioactive iodine therapy, and subtotal thyroidectomy. Spontaneous remissions of Graves' disease do occur and may last for years. Others will have a disease course that is persistent. Anti-thyroid drug has been used the longest and includes the use of PTU and MTZ, which those block the synthesis of T3 and T4. It may be 4 to 8 weeks before the child becomes a euthyroid on this therapy. The second treatment option for hyperthyroidism is radioactive iodine therapy. The third option is subtotal thyroidectomy and is used when adequate caregiver cooperation with drug therapy is not possible or when treatment has failed to result in permanent remissions. When we look at teaching, when working with a child with hyperthyroidism that is being treated with medication, it is important to teach the family the medication regimen, the side effects of the drugs, and the need to continue the medication despite resolution of symptoms of hyperthyroidism. Nurses should teach caregivers about the symptoms of hypothyroidism and provide guidelines for contacting the healthcare provider. Until symptoms disappear with drug therapy, children need a low-stress, low-pressure environment. Emotional lability may be evidenced by sudden episodes of crying and irritability or elation. If the child attends school, instruct the family on activity restrictions if medically appropriate. Nurses should discuss with school personnel restrictions for physical education and when these will be re-evaluated. Once recovery is evident, the caregivers may consider tutoring to assist the child who may have fallen behind in school or with school work. It is important to refer caregivers to a community resource for any local support groups or educational opportunities. I also want you to look at the table 28-2 in your text on 998, which goes over the side effects of anti-thyroid medications, and also your nursing alert, which goes over academic performance for children with hyperthyroidism. Now I want to look at just a few examples for these endocrine alterations. If you are teaching about the endocrine system as a school nurse, you will know they understand this system when they said infants have difficulty balancing glucose and electrolytes. This is true. For a child who is newly diagnosed with diabetes, the initial goal is not education. Although we think that education is key all the time, we are going to educate, but that is not the initial goal. The initial goal is developing management and decision-making skills. Once they have gotten that underway, then we can further educate them. When you are educating about precocious puberty, successful teaching would be indicated if the parents state that their daughter will start puberty once the medication is stopped. This is also correct. When looking at a child who has Graves' disease or hyperthyroidism, this would include moist skin, exophthalmos, which is the enlarged eyeballs, or the protruding eyeballs, shall I say, nervousness, and an increased basal metabolic rate. Okay, we'll finish up with the last few endocrine disorders, and we'll look at disorders of the adrenal gland. The first one being congenital adrenal hyperplasia, also known as CH. This is a group of inherited disorders in which genetic defect results in deficiency of an enzyme essential for synthesis of cortisol and at times aldosterone. I want you to go ahead and review the clinical manifestations as well as diagnosing. And I want to look at treatment really quickly. The goal of treatment here is suppression of the adrenal secretion of the androgens and prevention of progressive virilization and includes lifelong replacement of steroids and adrenal gland. Steroids the adrenal gland is unable to produce. The vast majority of individuals with 21OH deficiency will take both glucocorticoid, hydrocortisone, and mineralocorticoid fluorocortisone. When we look at nursing management and family teaching, nursing management of the newborn and adrenal crisis is focused on interventions necessary to maintain homeostasis through administration of fluids and cortisone and monitoring electrolytes and vital signs. Nurses need to also provide a safe environment for caregivers to ask questions and explore their feelings. Medication administration and the lifelong nature of treatment need taught to the caregivers. Cortisone is necessary to sustain life, and at times, when the oral medication cannot be taken, intramuscular injections need to be given. Nursing management for the child diagnosed later focuses on coordinating the testing for establishing the diagnosis. Most caregivers will have little understanding of adrenal function and will benefit from a lot of education. If the child who is diagnosed later has been diagnosed or has been assigned a sex that is not consistent with the child's gonads or chromosomes, the issues and focus of management will quickly include this new dilemma. Looking at disorders of the pancreas, we want to pay attention to diabetes mellitus, and I'm sure you guys are very much tired of hearing about diabetes mellitus, and you know it like the back of your hand. So we won't spend too much time on it. You know there's a type 1 and a type 2. I want you to go ahead and review the incidence and etiology as well as the pathophysiology if you have forgotten as to how it works. I want you to also look at the nursing tip on page 1002 or 1002 when it talks about the history taking in the evaluation of new onset type 1 diabetes. And we will look at the clinical manifestations really quickly, and these should be a review to you as well. The individual with type 1 presents most commonly with a history of polyuria, polydipsia, and polyphagia, also known as the 3 Ps, weight loss, and dehydration. In some individuals, abdominal pain will be present, leading to misdiagnosing of appendicitis or gastroenteritis. When we look at our children with type 2, this is the overweight population, the body mass index over the 95th percentile. Some with a history of polyuria that was mild in nature, others report significant polyuria, and others will report none. Fatigue and frequent infections may be present sometimes, but not always. The child with would also have ketosis. Table 28-3 in your text on page 1003 goes over the characteristics of type 1 versus type 2, so you do want to review those as well. When we look at diagnosing diabetes, the individual with type 1 can present with a variety of symptoms and ways from the most critical to the most stable. Most will also have experienced weight loss and fatigue. Some will present with diabetic ketoacidosis, your oral glucose tolerance testing, and fasting serum glucose determination. The historical hallmark used in diagnosing type 2 are not commonly needed for children because of the unequivocal presentation. The fasting plasma glucose is the preferred test to diagnose diabetes in children. The use of the A1C for diagnosis is not recommended. Diagnosis of the child with type 2 diabetes with symptoms is preferably established with fasting glucose level greater than or equal to 126 or a random glucose level greater than or equal to 200. If an oral glucose tolerance test is performed, the 2-hour plasma glucose needs to be 200 or using the glucose load of 1.75 grams per kilogram to the max dose of 75 grams of anhydrous glucose dissolved in water. If the child is asymptomatic, then the abnormality of glucose should be evident on 2 different days. When we look at treatment, there are various treatment options. Treatment for type 1 and type 2 ideally involve a team consisting of child caregivers and healthcare practitioners, the nurse, nutritionist, and mental health care professional. Each discipline begins to manage a unique and helpful perspective for the child and caregiver. The general goals of therapy for type 1 include achieving normal growth and development, optimal glucose control, minimum complications, and a positive adjustment of the disease. It requires daily injection of insulin, glucose monitoring, following a meal plan, exercise, self-management skills, and decision-making. The goal of treatment of type 2 is normalization of blood glucose levels and your hemoglobin A1C, achievement of normal growth and development, development of minimal complications, and positive adjustment to the disease and its management. Children who present with type 2 without metabolic decompensation may be treated with oral agents. In your text on page 1003 also, you can look at the table 28-4, which goes over some of the complications of diabetes. And as a review, go ahead and look at table 28-5, which goes over your insulin types and their action. I'm sure we all know how glucose monitoring should be done and how often it should be done. Even with the child, you can go ahead and review that section, as well as nutrition. That should be a review. You do want to look at the nursing tip in your text on page 1006, which goes over monitoring for long-term glucose control, the hemoglobin A1C. As another review, go ahead and look at the nursing tip in your text on page 1009, which goes over insulin injections. And figure 28-5, of course, gives you an illustration of the areas on the body that the insulin can be administered. Review hypoglycemia. If you need a review, you may already know what it is. You do want to note that there is a difference between a child and an adult. So I do want you to go ahead and review that glucose hypoglycemia and what to do as far as treating that. And you can go ahead and review hyperglycemia as well, and the differences that you may note with that. What we really pay attention to, especially for our hypoglycemia, is for our infants, or shall I say our newborns, of the parents that are type 2 diabetics or even the gestational diabetics. We do monitor the newborn for hypoglycemia. You can look at the nursing tip in your text on page 1011, which reviews blood glucose testing, and the nursing tip on page 1015, which goes over insulin infusions. You won't run into too many insulin infusions unless you're in a critical care area or a high acuity area. Table 28-6 in your text, also on page 1015, goes over the symptoms of hypo and hyperglycemia. Go ahead and review those if you do not remember the differences between the two. lastly, the nursing tip on page 1016 in your text, which reviews school nursing and type 1 diabetes. All of this information on diabetes should be a review, as you have covered this in basic, you have covered this in maternity, you may have also covered this partially in advance. So, there's only minute differences, especially, like I said, with hypoglycemia and monitoring the newborn when it comes to that. Now we'll look at, finally, additional endocrine disorders, the first one being hypoparathyroidism. This is characterized by a deficiency in the secretion of the parathyroid hormone, whose main function is maintenance of serum calcium. The impaired secretion of parathyroid hormone affects calcium phosphorus metabolism. This is a very rare disorder, and it can be congenital or acquired. When we look at clinical manifestations, the neonate may present with jittery movements, convulsions, apnea, lethargy, poor eating, and vomiting. Symptoms outside the neonatal period include tetany, stridor, Chavoski's sign, or Tresu's sign. And you may remember those when you were doing your cranial nerves. And want to look at treatment, which is the acute treatment in cases of seizures or tetany includes giving intravenous calcium in the form of calcium gluconate. The infusion should be given slowly, except in the rest of emergencies. Rapid infusion can lead to cardiac dysrhythmias. So calcium given IV is caustic, and exacerbation may cause severe tissue burns. When we look at Addison's disease, damage or destruction of the adrenal glands caused by tuberculosis, fungal infections, autoimmune disease, and HIV result in decreased production of adrenal steroids, cortisol, and aldosterone. The disease can also result from dysfunction of the hypothalamus or pituitary gland, or from discontinuation of high levels of glucocorticoids for treatment of other diseases. The presentation of Addison's may be as an acute or chronic problem. The acute phase is life-threatening with symptoms of severe hypotension, shock, electrolyte imbalances, dehydration, weakness, cardiovascular changes, fever, mental status changes, and hypoglycemia. An acute crisis can also occur with febrile illnesses, infections, or stress. Treatment for Addison's involves replacing the deficient or absent hormones. In acute Addison's, IV hydrocortisone is given at regular intervals, and IV hydration is given to correct the dehydration and prevent hypovolemia. When we look at Cushing's, this is a syndrome, that is a cluster of signs and symptoms caused by hypercortisolism or excessive circulating free cortisol. The most common cause of hypercortisolism in children is caused by prolonged or excessive corticosteroid therapy. The most obvious sign of Cushing's syndrome is the rapid weight gain, particularly in the abdomen, the face, and cervical fat pad, or the buffalo hump. Linear growth is decreased or stopped because the excessive cortisol suppresses the release of growth hormone. The child may complain of muscle weakness and also fatigue. The skin may be thin and fragile with an increased tendency to bruise. Reddish-purple striae appear in the abdomen, as might acne and increased hair growth in inappropriate locations. Treatment is, of course, based on the cause. Adrenal or pituitary tumors should be surgically removed if possible. When the cause is steroid therapy, it may be lessened if the medication is given early in the morning or on an alternate day schedule. Morning administration mimics the normal diurnal pattern of cortisol secretions. Alternate day administration allows the anterior pituitary to maintain a more normal hypothalamic pituitary adrenal control mechanism. And lastly, we will look at SIADH, or your syndrome of inappropriate antidiuretic hormone. This occurs when ADH, or vasopressin, is secreted in the presence of low serum osmolality. This is caused by various conditions such as CNS infection like your meningitis, head trauma, brain tumors, intracranial surgery, and certain medications like your analgesics, barbiturates, and chemotherapy. Clinical manifestations are related to water retention, include decreased urine output and weight gain. Gastrointestinal symptoms such as anorexia, nausea, and vomiting also develop. As the sodium level continues to decrease, neurological manifestations appear, including lethargy, behavioral changes, headaches, changes in level of consciousness, seizures, and finally, a coma. When we look at treating this, treatment consists of fluid restriction to correct the hyponatremia, raising the serum sodium level with intravenous sodium chloride, and increasing the serum osmolality. The underlying disorder should also be treated. And lastly, but not least, we will look at a few examples before we conclude this lecture. And when you are looking at interventions that are recommended for pancreatitis, positioning the patient in a fetal position, administering analgesics for pain, and of course keeping the child NPO to rest the pancreas, providing glycemic control is also necessary. When assessing the child's thyroid, one of the factors that can elevate the child's iodine level and invalidate testing is recent consumption of large amounts of cough medicine. When a child is experiencing hypoglycemia, the nurse may observe slurred speech, tachycardia, as well as diaphoresis. If you have a patient, let's say they're 3 years of age, who has diabetes that requires insulin, but her eating is sporadic, she will need a rapid acting insulin. And you can refer to your table within your text that goes over the types of insulin for your type 1 diabetics. These are especially needed when you have a child who has sporadic eating. It's not so difficult when you have an adult because their eating may not be as sporadic as a child. Lastly, you want to note that if you have a child on prednisone, then removed and appears gray with no pulse, the priority would be to immediately replace the cortisol. And usually we don't stop children on prednisone, especially when they have disorders that require this. We don't stop them abruptly. We kind of wean them off or titrate them downward. So you do want to note that. And that will conclude this lecture, which has discussed GI, GU, and endocrine disorders. Now that we have covered chapters 22, 23, and 28, please use this time to review and jot down any comments or questions or concerns that you may have, and we can address them in the next class.